Thank you very much, Michelle, for the introduction. I'm happy to be talking to you this afternoon or this morning, but I know some people might be joining us from other parts of the world. Permit me to share my screen. All right. Can you see my screen?
We can, Aziz, we do see the outline. So I see the slides on the side as well.
Okay. Then let me stop the share it again.
That looks great.
All right. Thank you very much. So like Michelle rightly introduced me, my name is Abdul-Aziz Seidu. I'm currently a second-year PhD candidate at the James Cook University, Australia. I'm happy to be talking to you this afternoon about the sexual and reproductive health care for persons with disabilities, specifically women with disabilities in Sub-Saharan Africa and Ghana in particular. Before I begin my presentation, I've put together what I call voices of women with disabilities as far as sexual reproductive health care issues are concerned. It is not that I don't want to go for antenatal care, but my problem is I can't move alone. They normally say, if I knew I couldn't walk to the clinic, I shouldn't have gotten pregnant. She, a health worker, said it wasn't her job to be helping cripples lie down on tables. I really felt bad. Another woman had this to share. When I gave birth to my son, I was sterilized at the request of my mother-in-law. It was done without my knowledge, but still, my husband having sex with me 4 to 5 times in a night, saying I have to give birth to a baby boy. So as we discuss these things, I just want you to be thinking about this. And these and many more are some of the issues we are going to talk about this afternoon or this morning or this evening. So this is the outline of my interaction with you. Look at the background, disability models, disability in Ghana, challenges women with disabilities face in accessing sexual reproductive health services, the way forward, and take-home messages. So globally, about 15% out of the over 7-point-something billion people are living with various forms of disabilities. And according to the World Health Organization, about 110 people are having significant difficulties in carrying out their daily activities. And the United Nations have defined disability as a long-term physical, mental, or sensory impairment which in interaction with various barriers may hinder an individual from participating fully and effectively in his or her societal activities. What this means is that if an individual is unable to participate fully because of a long-term condition, and in this sense, a permanent condition, that means that that individual is regarded to be disabled. And out of the 1 billion people, 80% are in lower and middle income countries, including Sub-Saharan Africa, the countries in the Sub-Saharan Africa. And from that same 1 billion, 40% are in Africa. And when we come to Ghana, according to the recent census that we did, that was in 2021, about 7.8, which is approximately 8% of our population are living with different types of disabilities. Globally, different cultures and different societies have their own conceptualization of disability. But then there are various models trying to explain the concept of disability. I'm going to discuss 3 key models with you this afternoon, and which is arguably predominant one is the medical model of disability. With this model, it regards the disability to be an individual issue or an individual problem. And therefore, it demands that an individual should seek medical care to be able to function effectively. So essentially, the individual is the one who carries all the problems as far as his or her disability issues are concerned. And that is also regarded as the traditional model or the traditional view of disability. So essentially, disability is caused by the physical, the individual sensory, or the individual mental impairment that prevents him or her from participating fully in social activities. And then also, they see the problem to be an individual problem. So you, the individual, you need to take certain steps to be able to take care of that problem, to participate fully in your society. However, some critics have argued that the medical model has a lot of limitations. And because of that, they have rather argued that disability is rather a social phenomenon in the sense that an individual is unable to participate effectively in social activities because of poor societal organizations. In this sense, if an individual is even disabled, but there are certain social issues that or social conditions that have made it easy for the person to participate effectively, then that individual will not be regarded as disabled. For instance, if you are talking about our environment, then there should be accessibility to public buildings. Then in terms of language, the individual should also be able to communicate effectively with other people in his or her environment. But if all these things are absent, then that individual is regarded as disabled. Another model is the International Classification of Functional Disabilities. But before that, I just want to compare the two models. So the social model and then the medical model. So the social model is saying that people are disabled by the barriers within their environment. So badly designed buildings, there are no lifts to public buildings, people are isolated in their families, there are few sign language interpreters, inaccessible transport and public venues, there are no special schools for these persons with disabilities to access, no ramps for easy movement, and then poor job prospects for persons with disabilities. Whereas the medical model is saying that people are disabled by the medical conditions. So those individuals should look for cure, and the conditions cannot make them work. They cannot work. They are mostly dependent on their caregivers, and they sometimes cannot hear or see. Based on the limitations of the social model also, the World Health Organization also came up with a model called the International Classification of Functioning, Disability and Health Model. This model has recognized disability as a multidimensional concept. And because of this, they have recognized that disability is both an individual or a personal issue as well as a social issue. And therefore, an individual is unable to function effectively because of the individual's own personal factors, that's the activity limitations and the issues within the person's environment. So they see disability as an impairment that limits people from actively participating in social activities, and the limitations usually restrict the person's participation in social events. Within our country, currently, about 8% of the over 31 million people in Ghana, which is about 2 million people, are living with varied forms of disability. And in terms of the gender dynamics, about 6.7% of males vis-a-vis 8.8% of females are living with varied forms of disabilities. So if you look at the statistics, the females percentage is even higher than the national average. In terms of rural-urban variation, 9.5% of the persons living with disability in Ghana are within the rural areas, compared to 6.5% in the urban areas. And in terms of the specific types of disabilities, the predominant groups, are those with visual impairment or those who have limitations in terms of seeing, followed by those who have limitations in terms of walking, remembering, hearing, and then the minute group is those who have limitations in terms of communication or speech. Within Ghana also, there are various sociocultural beliefs shaping people's perception about disability. And because of that, some cultures even use derogatory words to represent disability. In the Akan, for instance, which is the predominant ethnic group in Ghana, they call persons with disabilities, those with mental health conditions, as Jimmy Jimmy, meaning someone who is, excuse me to say, a foolish person. In addition to that, because of the sociocultural beliefs, there are two main views surrounding the understanding of disability in Ghana. The first view is that persons with disabilities or their families have wronged a deity or a supreme being, and this is also known as the religious model of disability. And because of that, people are always afraid to associate with persons with disabilities, with the notion that if they associate with them, they might also incur the wrath of these deities or the supreme being, which in effect might also lead those individuals to be disabled or their close family members, like their children or partners. A woman with disability had this to share. In our society, when you are sitting in a wheelchair, people think that you are bewitched. No one wants to be your friend. No one wants to be your family. No one wants to be close to you at all because you are going to curse them. The second notion is that they see persons with disabilities to be people deserving charity and pity. So this is also known as the charity model. And because of that, they mostly want to do something good to these people to also gain blessings from the supreme being or from God. And because of that, sometimes you see people giving money and other valuables to persons with disabilities just to support them. Now, gender and disability and sexual reproductive health. And sexual reproductive health here, I'm talking about anything relating to the individual sexual reproductive function and its processes. Generally, disability affects both sexes. No two ways about that. But the statistics indicate that women are those who are usually highly affected by disability. And in our parts of the world, Sub-Saharan in particular, in Ghana to be specific, some women are marginalized, especially those in the rural areas. And these people are already marginalized. And when they are living with disabilities too, it becomes a double agony for them. And sometimes women with disabilities are also forced into marriages. And in some instances, because of their disability issues, they mostly are not able to get stable relationships. So people see them as a burden, and sometimes they don't want to associate themselves with them sexually or to take them as long-term partners. And because of that, some people even see women as less eligible, women with disabilities as less eligible to marry. And because of this also, sometimes these women with disabilities mostly experience gender-based violence, and that in terms of the physical violence, emotional, and then sexual violence. A recent systematic review indicated that about 30% of women with disabilities globally have been sexually abused. And because of these sexual abusive nature and other things, these women are vulnerable to sexually transmitted infections, including HIV, AIDS, hepatitis, gonorrhea, and other. And these women sometimes also get unwanted or unintended pregnancy. They don't have access to safe delivery services, and even raising children becomes quite problematic for these people. And because persons with disabilities in general and women in particular are challenged in diverse ways. At the global level and national level, there are various interventions to improve the lives of persons with disabilities. And one of these interventions is the United Nations Convention on the Rights of Persons with Disabilities. That was done in 2006. After the World Report on Disability, that was in 2011, there was a need to develop disability action plan. And that one was done from 2014 to 2021. So it just ended last year. The main aim was to improve the health, functioning, and then the well-being of persons with disabilities. The post-MDG agenda, which is also known as the Sustainable Development Goals, have also included persons with disabilities, specifically SDG 3.8, which is talking about universal health coverage, and then SDG 10, which is also talking about social, political, and economic inclusion of everybody, including persons with disabilities. In 2019, too, the United Nations also thought it wise to institute measures to help achieve the goals in the Sustainable Development Goal. They propounded what they call the Disability Inclusion Strategy, which seeks to ensure that persons with disabilities are included in every sphere of national policies and national developmental issues. At the national level, too, in Ghana, to be specific, there are national policies and laws, and one of the laws is the Disability Act. There's also what we call the National Health Insurance Scheme, and then the Disability Common Fund. Just to talk a little about the Disability Act. The act was also passed in 2006, right after the United Nations Convention on the Rights of Persons with Disabilities, to ensure that the well-being of persons with disabilities in Ghana are improved. There is also the Disability Common Fund, which is about 3% of all the common fund that is given to the various district assemblies within the country to take care of persons with disabilities needs. There are also NGOs within the country to ensure that the persons with disabilities needs, their healthcare and economic needs are taken care of. Now, women with disabilities and sexual reproductive healthcare accessibility. Currently, over 180 countries have ratified the United Nations Convention on the Rights of Persons with Disabilities. Despite the widespread ratification and all that, many people still perceive that women with disabilities are not sexually active. And because of this, there is always low utilization of sexual reproductive health services among women with disabilities. And this low utilization has been grouped at the various levels within our country. You can look at it in terms of the national level, the community and family level, health system level, and then at the individual level, as far as the challenges to accessing sexual reproductive health services are concerned. So at the national level, there is generally low level of inclusion of persons with disabilities, including women with disabilities, in terms of sexual reproductive health policies. As part of my PhD thesis, I did a scoping review of all the major health policies in Ghana. And what I realized was that out of the 15 policies that I reviewed, only 8 of those policies included persons with disabilities. And even the level of inclusion, I looked at whether they have mentioned disability within the policy, whether those who enacted the policy, they included any disability organization or a person with disability in the enactment of the policy. From these, only 8 of that considered persons with disabilities. And some of the policies also even use derogatory words to describe persons with disabilities. So if you look at our criminal offense code, which is talking about the various offenses within the country, it also talked about abortion. And there are instances that abortion is legal within our country. And one of the instances was that if a woman is disabled, and to describe disability in that policy, they said a woman can seek abortion if she is a female idiot. And the use of a female idiot is a derogatory one. Also, Generally, there are unfriendly health facilities. Because of the nature of the health facilities within our country, persons with disabilities, especially those who have mobility challenges, are not able to use their wheelchairs to access sexual reproductive health services. And this is an example of what a woman shared in one of the studies that was conducted in Ghana. The entrance has a steep staircase that I can't climb with my wheelchair. And then, in terms of the public transport, the nature of the vehicles are such that those who are disabled sometimes cannot even take on board their wheelchairs to move to the various spaces or places that they want to access sexual reproductive health services. A woman had this to say, if I had enough money, I would just hire a taxi to take me there. I can't also use the public bus because I can't get into the bus. And then also, women with disabilities are less prioritized in pandemics in our parts of the world, especially in Ghana. When COVID was serious within our country, persons with disabilities were never mentioned. We never spoke about how to make healthcare accessibility and sexual reproductive healthcare accessibility to these people. Apart from that, there are community and family level barriers. And generally, in terms of the community, there's negative public attitude towards persons with disabilities. The general notion is that persons with disabilities and women with disabilities in particular are not sexually active. So whenever they see a woman with disability pregnant or seeking sexual reproductive health related care, they see it to be awkward. A woman shared this with me. When they heard I was pregnant, some of them were like, hey, why did she go to get pregnant? And then because of these things, they are always stigmatized and discriminated against. And because of that, people don't sometimes support them to seek sexual reproductive health care. And one woman also said this. My own brother asked me, why should I, a blind person, worry myself about giving birth? It was my poor dad who sacrificed his job money for me to seek healthcare. And mostly, these women are also sometimes abused sexually and physically. One woman also shared this in one of the studies that was conducted. On that day, he tied both legs with ropes and made me kneel down and had anal sex. It was intolerable, so I screamed, but he closed my mouth and beat me very badly. So at the health system level, mostly when women with disabilities go to these facilities to seek care, there's always a problem with communication, especially those with hearing impairment. One woman also shared this in one of the studies. Last time I went to the clinic to complain about some pain, I felt around my waist, but the midwife couldn't understand what I was talking about. She just gave me paracetamol and asked me to go home. And then the healthcare providers who are supposed to be delivering sexual reproductive health services sometimes even stigmatize against women with disabilities. A healthcare provider said this. Today, a healthcare provider were saying, you are personally dead. What do you want to space for? So virtually this woman was going to seek for family planning services. They said, men don't want you. Why do you waste your time? Why should you come for family planning? So those who are supposed to be promoting access to family planning and delivery of family planning services are rather stigmatizing against these people. How much more the community members? And then lack of training to meet persons with disability needs. Mostly, it is now that just recently, about 5 years ago, that they implemented a policy to include sign language and other things in the training of some of the healthcare providers. So those who were already trained before that time, they have not gotten that opportunity. And even those who just enrolled now, some of them are not even taking that serious. So those with hearing impairments, they sometimes come to these facilities and they find it difficult to communicate with them. And at the individual level, of course, most of them have mobility problems, especially those with physical disabilities, and then transportation challenges. And then the major problem most of these women with disabilities encounter as far as access to sexual reproductive health services are concerned is economic challenges. although the national health insurance in Ghana have exempted persons with disabilities, they only pay the registration fee, which is about 5 cedis. But even with that, a lot of them are unable to afford it. A woman had this to share in one of the studies. I have the national health insurance, but it doesn't cover everything. I had to pay with my chalk money. I couldn't even pay for all the medications they prescribe. So these things mostly prevent these women from accessing sexual reproductive health services. Now, the way forward, there should be full inclusion of persons with disabilities in sexual and reproductive health policies. And the inclusion should be done using international guidelines. Persons with disabilities should be prioritized in emergency situations. An example is what I just said earlier, the COVID-19 pandemic. There's always the need to also partner with the persons with disabilities. They have their specific organizations, the Ghana Blind Union, and they have their leaders also. Whenever there's the need to implement an intervention, a sexual reproductive health intervention in particular, then there's the need to partner with these people, because there's this popular saying about persons with disabilities, nothing about us without us. So if you plan with them, they will tell you their problems and they will tell you how and the way they want you to implement that. There's also the need for awareness creation and training. There's a need to sensitize people that disability is not as a result of wrongdoing of an individual. It can happen in diverse ways. Some people are even born with it. It can also happen as a result of accidents. As people age also, they become limited in diverse ways. So it is always important to create awareness and then the training of healthcare professionals to be disability friendly and also be able to provide services as and when necessary to persons with disabilities. There's also the need for support systems, and the support systems, it can be both formal and informal. So the formal one, the government of Ghana or the government of the various countries within our sub-region should ensure that there are social security measures put in place to protect persons with disabilities, and then the health insurance can also be strengthened. One of the things I picked from them was that some people, immediately they subscribe to it, whenever it's time for them to go and renew it, it becomes difficult for them. So they rather suggested that if it's just a one-time subscription, then you can use it for a lifetime. Any time you want to access healthcare, then you can take your card for healthcare accessibility. And then the informal one too should be social networks. Persons with disability, their family members and community members should take it upon themselves to access them as and when the need arises. And then there should be friendly sexual reproductive health services in terms of public buildings or health facilities. They should be built in such a way that those with wheelchairs and other things can easily access those facilities. And then some of the women with disabilities are not even knowledgeable about some of the sexual reproductive health issues. So it will be interesting to sometimes do peer leadership and then train up trainers on reproductive health issues so that their colleagues will then educate them on the need to seek sexual reproductive health, because some of them are also having different mindset about some of the sexual reproductive health products, especially contraception. They see it as something against their religion. Some people equate contraceptive usage as abortion. So all these things need to be taken care of in terms of education. And then there's also the need for more evidence-based research to know the plight of these women with disabilities. So in conclusion, persons with disabilities represent a significant portion of the world's population and are part of every community. The sexual reproductive health needs of persons with disabilities are often overlooked because of the notion that they are not sexually active. But in real essence, evidence even suggests that some persons with disabilities are more sexually active than persons who are not disabled. And because of the notions within our society, the experience experience a lot of barriers, including access to sexual and reproductive health services. There's therefore the need of women with disabilities and persons with disabilities in general to be prioritized to help in the attainment of the various interventions that we put forth, specifically the Sustainable Development Goals that seeks to ensure universal health coverage. Thank you very much. This is the end of my presentation.
Thank you so much, Aziz. That was wonderful. So I am going to welcome everybody to start a conversation now. So feel free to just unmute, use the hand raise function, or to use the chat to pose any of your questions. And Jennifer, do you want to kick us off?
Sure. So I was wondering if you're aware of any initiatives in Ghana to change healthcare provider perceptions of people with disabilities, and if any of those have been effective, because this is also a challenge in the United States, is changing healthcare provider perceptions, and it's really difficult. So I'm interested what has worked well in Ghana.
Yeah, generally, apart from the Disability Act that was passed in 2006, and then they developing the curricula for the healthcare providers in terms of their training, there hasn't been any general intervention targeting healthcare providers.
I have a bit of a follow on that. I don't know if you did as well, Jen, but we have a few students that are really interested in kind of continuing education and skills training for healthcare providers. And I'm wondering if you can talk a little bit about how that's currently implemented, Aziz, and if there is much kind of time and space to implement some of this additional skills training, because I could see this being an area where there could be some skills building and training once people are in the healthcare systems or clinics.
Right. Thanks for that great question. I think it will be interesting to do that. Currently, apart from what they train them in schools, there are no even in-service training for those who didn't get the opportunity to participate in that. And even the one, from my informal interaction with some of the students, the one in the school has not even been that effective because they are only looking at only sign language, which is just one component of that. And even the sign language, there are few people to teach these students, because one school, you might have about 3,000 people or 3,000 students, and just one person taking all of them through the sign language sometimes makes it very ineffective. Yeah. So it will be an interesting thing to do.
Thank you, Aziz.
Welcome.
Any other questions or comments? Again, please feel free to use the chat, raise your hand or unmute. I had a question about the data, Aziz, that you presented more towards the beginning of the presentation. Okay. And so you showed the percentages of people with disabilities living in rural areas versus urban areas. And it was actually higher in rural. So I think it was like 9.5% versus like 6.5% in urban areas. And I wondered if you could talk a little bit about that. Is that because the majority of the population is in rural areas, or just really difficulty with transportation and people kind of staying in smaller communities versus a larger city where there might have to be a bit more moving around?
Okay, thank you very much for that question, Michelle. Generally, the world over, most people with disabilities are found in the rural areas. And I think the picture is not different from Ghana. One main reason is that because of their challenge in terms of some rehabilitative services and other things, whenever they are confronted with a disability, the possibility of they getting, should I say, care or rehabilitation services sometimes becomes a bit limited. So unlike those in the urban areas who might have access to rehabilitation and other support services, those in the rural areas are sometimes disadvantaged. So it's partly one of the reasons. Yeah.
Thank you, Aziz. Go ahead, Julie.
Thanks, Aziz, for the wonderful presentation. I really appreciated, your great suggestions for the way forward. I thought they were really helpful suggestions. I wonder if you could speak a bit more about, some of the cultural influences that you mentioned. People feeling like they were cursed, or that being disabled was somehow something that they had done wrong to offend deities, and related to that, how the way forward in terms of trying to educate and do some public health sort of initiatives about that significant cultural shift that might need to happen. If you can maybe talk a bit about that, that would be great.
Okay, thank you for that. So in our parts of the world, like I explained earlier, most people feel that people are disabled because of their wrongdoings. And because of that, they are mostly afraid to associate themselves with persons with disabilities. And sometimes because of this also, whenever there's a need to support these people to seek whichever care, be it reproductive healthcare or healthcare in general, they are afraid to do so, leaving these persons with disabilities to fend for themselves. So currently, if that is done, the education is done, then people will understand that the disability people are confronted with is not their own doing or the wrongdoings that they've done against a deity or something. Then we'll be able to change people's cultural interpretation and understanding of disability issues. Right now, some people are even afraid or shy to bring out their children who are living with disabilities, all because people will say, oh, if I associate with this family or this person, the stigma alone is not making it possible for people to come out, those with disabilities to come out. So some days ago, I interacted with one of the leaders in the Offensive North District. And he said one of the things they've taken upon themselves to do is to do community home visits. So whenever they hear that there's someone living with disability in the house, they will go and talk to the household leader that they have an organization or an association like this. Bring the person so that so the common fund, for instance, they share it among those who are registered members. So if the individual joins that particular group, whenever there's an opportunity for them to access any fund, then that person can also get that fund. So with that, with time, people appreciate the fact that disability is not just a wrongdoing to the deity or something. Yeah.
Thank you.
Welcome.
Thank you, Aziz. Narcissa?
Hi, Aziz. Thank you for this presentation. My question is, have you found anything in your studies about the increase in intimate partner violence with women with disabilities as opposed to general population? Do you know if there's a higher intimate partner violence percentage versus general?
Yes. Generally, for my PhD study, I used a mixed method approach. So the first one was a quantitative one. The numbers I got was not that much, but the qualitative interviews, I'm now picking some stories from what they shared with me. Recently, one woman indicated how a man usually scaled their wall to come and harass her. And because of that, she got unintended pregnancy. She attempted aborting it, but the mother had to talk to her that, don't abort this baby. You don't know what that baby might come to help you in life. And she showed me that baby. Now, that child is the one supporting her in the house. She's about 16 years now. So generally, in terms of my personal study, the numbers were few. Out of about 402, it was only 3.1% that indicated that they have ever been sexually abused. The major form of abuse is the emotional one. People usually stigmatize them because of their condition. But generally, in terms of worldwide statistics, evidence suggests that women with disabilities are more subjected to sexual violence.
Thank you.
You're welcome.
Aziz, I would assume that there is a great deal of underreporting with that as well, similar
Absolutely,
to all forms of gender-based violence globally.
Yeah.
Especially if there is this kind of stigma, and I mean, you know, the comment you just mentioned. It'd be interesting to talk to that person about whether or not they would report that, you know, what they would consider that a form of abuse or not. Thank you for the question, Narcissa. Fat, do you want to go ahead and go next?
Hi, Aziz. Thank you for that presentation. I think my question is that, can you kind of elaborate more on interventions related to like involving family members or the partner themselves into the care of women with disabilities, and maybe like educating, like providing education and informing those like around their social circle about it, and what sort of like format or form do you think would be the most successful for this to occur?
Okay, thank you very much for your question, Fat. In terms of the format, generally within the various communities, we have what we call community radio stations or community, they call it community information center. That is one of the key strategies. Another strategy is to target the household leaders. So usually if you target a household leader, then they more or less, whenever they are educated about how persons with disabilities should not be stigmatized, then they also go and educate their family members. Yeah.
Thank you.
Welcome.
Go ahead, Jen.
So a lot of worldwide data shows that people with disabilities are disproportionately affected by disasters. And you mentioned this in your presentation when you were talking about COVID-19. And I'm wondering what you were seeing in Ghana related to COVID-19 and discrimination against people with disabilities over the past couple of years.
Okay, thank you, Jen. Generally, one of the key things I saw based on personal observation was that when the COVID-19 vaccines came, persons with disabilities are part of the marginalized groups, but they were not part of those they prioritized at the beginning. That's one key observation I made. And I also got that from the interactions I had with them with my qualitative data collection. Yeah.
Aziz, I have another question. So I know you've been working in university environments for the last few years that I've known you. Are you seeing any work being done in the university setting to really think about people with disabilities and their access to the university campus, education, and kind of all of the services on campus? I know that's a little peripheral from this, but I'm just wondering what you're seeing at the university level as well.
Yeah, at the University of Cape Coast, a colleague looked at their persons with disabilities, their access to healthcare in general, especially the university hospital. And then one colleague also looked at their challenges surrounding their movement within our environment, how our pavements are, the road signs and other things. Yeah. And my master's thesis was also on the use of sexual reproductive health services among young people with disabilities. So there are special schools within the country. There are currently about 16 of them. So I collected data from all these schools. Yeah.
So are you seeing any changes from these studies and from this data?
Yeah, a bit. So with the young people, I realized that because of the formal support they usually get from the schools and NGOs, their use of sexual reproductive health service was relatively high, about 60 out of 100. Yeah.
Great. Thank you. Jen, you can go ahead again.
Yeah, I just wanted to piggyback off of Dr. Monroe Kramer's question. And I was wondering if there are any statistics on how many healthcare providers in Ghana are people with disabilities, and whether there are any programs to recruit more people with disabilities into healthcare careers.
Thank you, Jen, for that great question. From my readings, I've never come across anything like that, but I'll try and find out. Yeah.
Thank you.
It's your next study, Aziz.
Sure.
So I have a follow-up question on that. I'm Megan Eagle. Thank you so much for your talk. This really is an issue that we think about and contend with here as well. Kind of the question about healthcare providers, you know, of course, it helps change the system if people in the system actually have that perspective. But to get there, you know, you're seeing some positive impact of there now being access to education, even if it's through the special schools, right?
Yeah.
Where
Yeah.
the generation that had the opportunity to go to those schools is accessing healthcare more than generations before them. What do you think steps might be to help that generation actually access university level education?
I think it will be a great opportunity to change the current practices, because just like I indicated earlier, nothing about us without us. So if we get more of persons with disabilities also taking up or joining the health training school, that would be a great thing. Yeah.
I have a big question that probably doesn't have an easy answer, but I think is an important question. And so you talked a bit about stigma and just these perceptions that I think really exist globally, that people with disabilities are not sexually active. And so we don't even really think about providing education or addressing kind of family planning and sexual health needs. And I think this perception kind of exists globally with youth too. Like we think it's just not happening. And so we don't always provide those services to individuals that we don't think are engaging in sexual activity. And so how do you think we can start to really combat these myths? I mean, I think it's a big thing, right? We can do some training and education, but it really seems to be kind of these deep-seated perceptions that have to change at like individual healthcare provider levels, kind of system levels, as well as some of the policy levels you talked about. Do you have any thoughts on kind of a way forward to do this? I really think it's globally. Aziz, I know you focus quite a bit on Ghana and Sub-Saharan Africa, but globally.
So I think it should be a multidimensional way of educating people about the sexual and reproductive health needs of persons with disabilities, right from the community level through to the health system level and then through to the national level. Because if you get the community members to also appreciate the fact that persons with disabilities are also sexual beings, and because of that, they are also sometimes in need of sexual reproductive health services. If you get it right from the base, then it will be easier to tackle at the general level. So that should be done in consultation with the various policy documents to enforce some of these things that have already been implemented. Yeah.
Thank you. I think, at the University of Michigan, we actually have a reproductive health clinic for women with disabilities, which is terrific. But I mean, I know it doesn't exist around the state or even kind of nationally. So it seems there are these little pockets that might be doing a pretty good job meeting the needs of individuals, especially, if we're thinking about sexual and reproductive health for women with disabilities. But I think it's hard to figure out how to translate that, right? Like it takes providers with that education and some extra resources to do that too. Big question. Any other questions or comments for Aziz? Again, you can just feel free to unmute, raise your hand, or use the chat. While we're waiting a second, Aziz, I just want to thank you again for the wonderful presentation. I think this was a great conversation after words as well that really focused this discussion on globally, thinking about sexual and reproductive health of people with disabilities. I know some of you joined us a little late, so I just want to remind everybody that we have one more Coffee and Conversations next week on June 21st. Megan Eagle is going to host and moderate this, and we have Dr. Nar Singadong talking about non-communicable diseases, particularly hypertension in Thailand. And I also just want to say thank you for everyone for joining us. I see some new names today. I see some names that have been joining us throughout this session. And we've really enjoyed these Coffee and Conversations. I know the students have also really enjoyed the opportunity to hear from different speakers and to engage in a bit more of a conversation. So if you have ideas for the future or colleagues that are topics that you think would be great to discuss, please let us know. We're always looking for great speakers and new ideas that we haven't talked about in the past. So I am going to throw my email in the chat, and you can feel free to reach out to me if you have other suggestions for speakers or topical ideas. All right. You're getting some kudos in the chat, Aziz, but I don't see any additional questions. So we'll go ahead and stop a few minutes early today. And please feel free to reach out with suggestions or questions. And we'll see everybody again next week.
Right.
Thank you.
I appreciate the opportunity to discuss this with you. Bye-bye.
Bye. Thank you, Aziz.